back to the show. Your host, Reem Al Brahim, and of course, I have my friend and co host, Diana Ruan. Today, we're going to touch and tackle one important subject that usually understood and most of people ignore it, which is palliative care and the end of life care. So, we have Dr. Lee Pan. Lee, how are you doing? Thanks for coming.
I'm doing great. Thank you for having me. It's an honor to be able to speak on my limited experience, but I feel very strongly about this field.
And can you do a quick self-introduction?
Sure. So my name is Lee. I am a palliative and actually hospice and palliative medicine trained physician. I originally trained in internal medicine, and then I pursued a fellowship in hospice and palliative care. So these days I do primarily inpatient palliative medicine consults for people who are in the hospital with very serious medical conditions and usually have some chronic illnesses as well that we can't cure. So I find a lot of joy in being able to help some of these people with what they're going through.
So, touching on that, what do you mean by palliative care and how is it different from hospice care? For like our listeners, I don't think everyone knows.
Yeah, and I think that's a question that we're probably going to keep getting asked. People in our field will still have to answer for many years ahead of us. So palliative medicine in essence is supportive of what the regular care is, right? So it can look different for everybody, but our main goal is to make sure that people understand what care they're getting, like what conditions they have, what potentially is their prognosis if they want to know, and also what are the treatment options or lack thereof that's being offered to them. And the difference between us and hospice, which is the primary confusion part, is that hospice falls under the umbrella of palliative care. Hospice is palliative care, but for very specific, like less than 6 months to live on average. And they have to either have foregone life prolonging treatments, like they're no longer seeking cardiac interventions or cancer treatments, and instead they just want to focus on comfort and quality of life. Sometimes people end up at the hospice stage almost against their will because the doctors say, hey, there's nothing we can do for you anymore. Only hospice can help you now. So palliative care, I would say, is something that people can benefit greatly from even the moment they are diagnosed with something like CHF, COPD. Cancer is a very common diagnosis for palliative care support.
So, palliative care is hospital based.
Oh, that's a great question.
Yeah.
So palliative care can be outpatient and inpatient. I am primarily inpatient, but there are also outpatient clinics. The outpatient clinics are, in my experience, primarily attached to an oncology office. Okay. So oncologic patients benefit greatly from palliative care. But I don't think that's because palliative care is only suitable for cancer patients. It's actually because we're so new that other fields haven't really adopted it yet. Okay. So I'll give an example, like the American College of Cardiologists and AHA, as well as the kidney doctors, they have all internally met and said, hey, we need to start looking at the care we provide differently and involve palliative care way earlier on so that people can understand their medical journey better and make wiser decisions for themselves and have fewer regrets truly when it comes to like the end of that disease. When it becomes terminal stage, they will have less regret and feeling like they have, feeling less so that they have been led on for a long time and suddenly blindsided by the fact that, hey, there's nothing we can do for you anymore. Okay. So it reduces that. So palliative care really is valuable in working side by side with these specialists to help reduce symptom burden and answer crucial questions that they may have that the specialists just frankly, they don't have time, unfortunately, to spend with them to really get them to understand with that deep level. So that's where I think the value of palliative medicine is we can support any medicine, but we just fortify people's knowledge and their comfort as they're going through the medical journey. Because my personal belief is that in life there is suffering, but there are things that are worth suffering for, and then there's suffering that just doesn't need to happen. Unfortunately, with the medical system these days, everyone's so focused on the medicine, we hardly ever take time to ask, hey, how are you doing? How's your family doing with all this that's going on? And in that sense, a lot of suffering is missed. People come to the office, they put on a brave face, and they nod yes and yes and yes and yes, and then go home. They're like, I have no idea what happened at the doctor's office, and I'm so stressed out, and like I feel so bad about how my doctor talked to me. They talked to me for 10 minutes and pushed me out the door to tell me to come back in 2 months to do the same thing.
So it's sad because they are treated as a number.
Yeah.
When you look at it, they have stories. They are exactly like us, but we forgot that. Totally. We just, there is no connection on a human level, unfortunately.
And that's what we try to bring in, is that human connection, the active listening, asking follow-up questions to what patients are telling us, rather than just having a checklist in our mind going, boom, I need to answer A, B, and C, and then, okay, done, next patient, A, B, and C, done, next patient. We're trying to move away from that assembly line medicine, if you want to think about it that way, to truly bring back personalized care. So, and I think a lot of palliative practitioners will agree with me that palliative care is just good medicine. I actually heard that from one of my colleagues, old bosses. Like, they think that palliative care truly is just good medicine, and I wholeheartedly agree. Because we're just trying to help people make the best decisions for themselves so that they can live their best lives.
Yeah, I remember reading Dr. Pan, not you, Cynthia Pan book, and she was talking about all of the connection, the human connection, and how she ended up doing palliative care. And it was very interesting because she brought back like the connection to medicine, and she loves it, so it was interesting.
Yeah. So I can speak about that myself too. When I came into medicine, I had little idea about what I really wanted to do. I had this vague idea like, hey, I want to just help people. So originally I wanted to go into emergency medicine because I was like, hey, saving lives, that's cool, right? And then I had, my training was during the COVID-19 pandemic. And unfortunately, I saw many people die. And I spent a lot of time in the ICU. And I started thinking to myself, like, despite everything that we do, people aren't living longer, unfortunately, during that time. And also, they were suffering a lot despite what we do. And sometimes because of what we do, they were suffering. And at that time, I just remember very distinctly, like, family members were not able to visit the hospital very often. Like, they have, especially in the ICU, they were allowed to visit maybe an hour a day. And so in my head, I was just like, we're doing all these things for all these very sick people. And statistics tell us that 20% of everybody who goes to the ICU will end up dying. It was probably higher during that time, because I was feeling like maybe over 50% of the people that ended up in ICU because of COVID at the time ended up dying. And so I was like, this is so sad that we can't make the person understand because they're intubated on machines and they're dying. And we also can't help the family understand because we're so busy and they only have 1 hour a day to visit. Sometimes they don't visit at all because they were scared they were going to catch COVID. So there was a huge disconnect at that point to me where I'm like, I don't feel like I'm actually helping anyone here. I'm just trying to prevent people from dying, but am I actually helping people, or am I just, doing procedures, escalating like how much medical stuff we're doing to them? And me all the while, like, their body just decomposed right in front of me. And like, it was a great deal of helplessness actually that I felt within myself. That I'm just like, there's got to be a better way of doing medicine that I can make a better impact. And I think that's ultimately what drew me to this field, because I still get to see the interesting, like very complex patients. But at the same time, I feel like I'm making a very big impact by sitting down and spending time with the people that really need that extra time and explanation. So over the course of the past 1.5 years that I've been a palliative care attending, I really have gotten like a lot of good feedback and saying, and people generally just say like, that was really helpful. All we did was talk, but that made me feel better. And that's part of the thing where sometimes, even though I'm not giving any medications, I'm still practicing medicine by just talking to other people.
You're helping them.
Giving that reassurance and like, hey, someone's listening to you, listening to your concerns and answering your questions. It's very basic, but it's kind of a shame that's not being done as much anymore.
Yeah. Well, before jumping to the next question, what do you have in mind?
Yeah, so as I was listening to the first part of what you were explaining when you were defining palliative care and hospice, and also your perspective on both of them, I realized that it ties a lot back into my like personal philosophy. A particular point is that like the experience that we feel, our experience of our emotions and what we feel is very much tied to whether there's a difference between our expectation and our reality.
Oh,
And it sounds a lot like what you provide in palliative care is a clarification of a higher quality expectation, higher quality reality that you're also able to provide, and then maybe bridge the gap between what that distance actually is.
Yeah.
And so the distance, that difference between expectation and reality makes all the difference also about what you feel. And so it sounds like a lot of the results that you get are a result of just higher quality questions leading to higher quality answers and more clarity with the plan and what to expect and what actually happens.
Yeah, I think that's a great way of putting it. It's to align people's expectations and their perception of reality with our perception of reality a little bit better, so that we're all on the same page. We're like a lot of times I find doctors are talking up here and the patients are talking to them down here, and
That's most of the time.
that's most of the time. Yeah, I think I sugarcoat that. That's most of the time. And there's this thing where we say, oh, patients hear what they want to hear. But I don't think that's strictly true. It's like patients hear what you're trying to tell them, but they don't fully understand what you're telling them. And like in your mind, you're painting like a very grim picture, and all the patient heard was, oh, everything's going to be okay, because the doctor was afraid of asking like, hey, what's actually important to you, so I can explain things in a way that makes sense in your reality.
Oh wow, that sounds like the key question that you ask people, what's actually important to
Mm-hmm.
you.
I
And
ask
then the
every one of my
reason-
patients that.
And then the purpose behind the question is so that you can meet them where they are and speak to them.
Right.
Like actually speak to them.
So I think like my job is 90% communication. The medications that I use is like whatever. You could spend a month and you'll know it. But communication takes so long to develop actually. And that's absolutely right, is that the first step is to make sure that you have good communication and you have trust. You build the trust, you communicate well so that they understand where you're coming from, and they're more receptive actually to your recommendations once they know that you're asking questions because you want to know what's important, what their goals are, and they feel that they're like, this doctor has my best interest in mind. I'm going to be more honest with him. I'm going to tell him things that I forget or even just don't want to mention to other people, because he's really looking after my best interest and he's going to guide me through this. Like that's my goal when I speak with people. And the reason behind that again is because I want people to do what they want to happen for themselves, right?
Yes. Well, we're gonna help that. I love you. What was wrong?
Looks sleepy.
خلص شغل تعالي جيبها
يلا خلص الشغل روح تروحي الناس وتعالي يلا
ما حبوا تعالي نتفرج
طيب هسه راح تروحون بارك يلا.
Man, now I can't untaste the pickles.
Oh really?
He loves pickles.
Yummy pickles pickle.
You like pickles? I love pickles.
Oh, yeah. Come on, Zach, not here. The other way. Come on. Close the door behind you.
Oh, Dad, about some pickles.
Oh no, I sent him on a pickles rush.
Come on. Zach, no.
Sent him on a pickles tilt.
Come on.
He's
Yes.
tilted on pickles now. The dog's like, what's going on?
They really are like little minions.
They are. They so are.
Especially Zach, he looks like a cartoon. So, in defense of physicians,
Yes.
I think they were programmed, and with the burnout and short of time
Mhm.
having the patients, they try to focus on what's important to them as what they learned. That
Right.
it is important. And in med school, we've learned not to. I feel like we've learned that we have to have a wall, even though
Yes. Yeah.
we have to show them that we're human, we understand, we validate, but still we have to have a wall between us and between the patients. So
Yeah.
I think we need to get back to connection as souls.
I agree with that. So it's very hard. Like I was trained the same way, and they're still training people the same way. It's
Yeah.
like, hey, we're gonna make you drink from a fire hydrant of all this medical knowledge, and this is all that matters.
Yeah.
And then there's like 2 days of medical ethics and
Yeah.
and like how to break bad news. There's like one test on how to break bad news, right? So it's no surprise that we're training so many doctors that come out and their minds are just made up of checklists and algorithms. They see a list of their, when you first start out, you're an intern, you maybe start out with 6 to 8 patients. And as you get more and more experience, now you're at 15, 16, maybe even 20 patients. When you have so many patients and only so many hours in the day, you still have to write your notes, you have to round. Every patient you're only spending like 5 to 10 minutes with.
Yeah.
And so the question is, how do you ask all these questions with the 5 to 10 minutes that you really realistically have? Because the patient care, 90% of that is done outside of the patient's room, on the computer, talking with nurses, talking with social worker, talking with everyone else except the patient and their family, right? And in my opinion, the answer is you really can't. I mean, you could try, but unless the system changes. But right now, the way the system is set up is like you have to see a certain amount, or else we're going to fire you, or you're not going to get a bonus, right? You're not going to get paid. You're not going to get a job if you can't see more than 18 patients a day. Like nobody's hiring people who can't see.
18?
Yeah, like when I was looking for like a hospice job, they're like, hey, we ideally want you to be able to see 18 people on average over a course of a 12-hour shift. I'm like, that's less than an hour per patient. You understand? Like even if I just spend all my time talking with people, that's less than an hour per patient. And so all these and nowadays, I'll just give you a perspective. So on average, for new encounter, when I'm first meeting a patient, I'm probably spending on average 45 minutes to an hour with each person, just to dive into, get them to show me that they understand what's going on, and also to dive into what's important to them. And I think the reality is that my job exists because there is that deficit, right? I always say the standard of care works for like a good 80 to 90% of the hospital population or patients that come to us. But then there's that 10%, 15 to 20% that fall outside of that the standard really doesn't work. You have to do some more exploration because they're just so sick, or their socioeconomic factors are just so complex that it bleeds into what's going on with them medically. And so without spending that time to understand what people want, you're just going to say, okay, here's the standard of care. They're going to say, all right, I'll try it for the 16th time. And they try it, they get optimized in the hospital, they try it, and then they fail at home, they come back to the hospital for the same exact reason. And so for me, what I try to do is try to break that cycle. It's like, how can we work together to make sure you get what you need at home? Sometimes it really is like there is only so much we can do as the medical system. We don't have infinite resources. I wish I did, but within our power, I think there is always things that we can do better, like inform people better so they make smarter choices for themselves.
I always believe in prevention, to be honest. Once I went, I was in the system, I'm like, why do we wait that long? Like, why don't we increase the awareness of like, if you do this, that's what's gonna happen? Because most of people didn't know, especially like the older generation. They didn't know, like, the cans, like food, processed food. No one knew about it until now, like a few years back. Like, this is actually causing diseases, causing ADHD, causing cancers. So now we have the resources we need to increase the awareness, not to get to that end of life stage or end of disease or whatever it is.
Right. Like when you develop irreversible disease at that point, then you're going to get chemotherapy to further poison your body, so to speak. It's not ideal, but yeah, and I don't know how to change it. I don't know how to fix that. I don't have the answer to that.
Change the system.
You got to change the system, but that takes, I think so, and that takes the work on the behalf of doctors, but also patients have to have that mindset.
Yeah.
Because a lot of times it's also like people coming to us and they expect a miracle cure. Like, we don't really have that.
That goes back to knowledge and awareness, because if they know that their lifestyle or their habits caused that, then they have the choice to do it. They want to blame a doctor or a physician if they didn't do a miracle for them.
Yeah.
Well, I feel like both ways need some more knowledge and awareness those days, and I feel like PTI is the, Gandhi, the quote of Gandhi when he said, "Be the change you want to see in the world." Like, we're doing that.
Yeah, I think it demands, in order to fix the system, it demands a cultural shift as a whole. Yeah. Like, it's tough because the popular media still very much so like disseminates things that are not good for us, and they're like glorifying it even. So it's kind of an uphill battle to try to get people to understand some of these things.
That's true.
Yeah.
So I was thinking of timing. So at what point in a serious illness journey should a patient be referred to for palliative care services? Is it only when treatments fails, or how does that
So in an ideal world with near limitless resources, I would say that the moment you're diagnosed with a chronic incurable illness, you should be seen by palliative care. And the reason behind that isn't to say, oh, okay, I'm going to start describing end of life to you at that point. The reason for that is to just say, hey, first of all, you just got diagnosed with something huge. Like, do you feel well supported? Right? Like, do you need to talk about that? Because a lot of people, they live with these, like, oh, I have CHF now, but who do I talk to about that? Just my cardiologist, right? Who keeps telling me to take medications and do cardiac rehab or whatever. But they don't really have an outlet for that. So to provide that support, like, hey, you just got some serious bad news. Do you want to talk about it? Like, what does this mean? What does this mean to you and your life, your way of life? And then at that point, you could start to pinpoint, okay, what makes this person's life worth living to them? Okay. What makes them excited to wake up every day? What do they hold near and dear to them? And at that point, once you've identified those things, you can disseminate that information to all the specialists caring for this person to say, hey, this is what we're trying to protect for this person. Yeah. Otherwise, what I find is everyone just operates the same way, standard of care, like, okay, here's your medication, here's your echocardiogram, here's your EKG, come see me in 3 months, and we'll do it all over again. Up until the point where your heart fails, then we'll send you to hospice. And then people are like, what? I thought you could fix this, It's like, I thought this was curable. I thought all the medications you've been giving me this whole time was curing my heart disease. And nobody ever told them, like, hey, this is something that eventually probably will kill you. Because people don't feel comfortable with that conversation. They're like, oh, if it's 5 years from, if the data shows me that someone diagnosed with heart failure has on average like 5 years left to live, why would I have that kind of conversation? Why would I start that kind of conversation way earlier?
5 years is very fast.
And
It's very fast to pass. Trust me.
I would live my life differently.
Me
if I
too.
knew that
and
I
that's
only had 5
exactly
years.
my point is, who are you to decide when someone should know their
Yeah,
prognosis?
that's true.
I think if people want to know, like, hey, what does this mean in terms of how much I'm going to be able to do? Not even just stay alive. Like, if I can't go out and take a walk anymore every day, maybe I don't find that life enjoyable. And it's giving that heads up so people don't get blindsided by their eventual decline due to their underlying disease. And I think that's so important because, like you said, people have plans. And if they knew that, well, first of all, you have to ask permission. That's always the thing. Like, ask permission to see if people want to know. But most people do want to know that if they knew that, hey, likely there's only a few years left of my life. I want to go to Europe. I want to go travel. I want to stop working. I want to quit my job, retire, and spend time with my family before I can no longer do those things. Instead of working with CHF and then going to the doctor or cancer or whatever it may be, going to the doctor until the very bitter end and then say, oh my God, I've wasted all that time and now all I want is spend time with my family. Like, there's not enough time that I can spend with my family. And I just see that all the time. And there's a lot of, unfortunately, where I practice at least, there's a lot of gatekeeping of that information by the cardiologist. Or cancer doctors, whichever, they'll say, oh yeah, palliative care, not time for you to intervene yet. And I'm like, well, I'm not going to tell them to enroll in hospice. I'm not going to encourage them to die. Like, what are you worried about? Like,
So
and
there has to be awareness for physicians about that.
yes,
Too.
yes, their own colleges and their own organizations are encouraging this, but they have not adopted, right?
But I don't, like, palliative care for me is new.
Mm-hmm.
Like, I was introduced to it once I read Dr. Cynthia Pan. Like, we had a conversation. But before that, I didn't know that existed.
And
Yeah,
that's why we have this
brings up
Yes.
another good point and issue is that palliative care for most of the rest of the world
It's not
doesn't
there.
exist.
Yeah,
Yeah,
for
like
me,
in
back
Asian
home,
countries, like maybe Europe has some palliative care, right?
Yeah.
Maybe,
Yeah.
but places like South America, like China, Taiwan, there's no
Our
palliative
country,
care.
Like, I was like, maybe that's a new branch. And it is a new branch
It
because
is.
we don't have it back home.
Yeah, so it's not as ubiquitous as
Yes.
cardiology, as nephrology, as pulmonary, as
It's
oncology.
very important.
So then I have a question.
Yeah.
What is the origin of palliative care then?
So
Is there like a history?
yeah, there is a history. So at some point there was a
I'm sorry to interrupt.
Sure.
Feel free to like adjust
Oh.
the chair, whatever.
no, I'm comfortable like this. At some point, people in nursing actually, so palliative care was born from hospice. There were a group of nurses and doctors that felt like, hey, people are not comfortable at end of life. They're suffering, and at some point it's like, oh, you do traditional medical care and it works, and then everything falls down a cliff, and then people really suffer during the last few days to weeks of their lives with no support. So there's a person that comes to mind, Dame Cicely Saunders. She is a nurse, and she essentially is the mother of hospice in the United States. Like, she basically came up with the idea of hospice. The term was coined previously by like surgeons and stuff like that, but never really implemented until Cicely Saunders really started the first hospice in the United States. And what she did was so profoundly impactful, and people loved it so much that it just spread. So hospice actually came first. And then people at some point realized, hey, so I was listening to a podcast by Jerry Powell and then the founder of the AAHPM, the American Association of Hospice and Palliative
You
Medicine.
just hurt my feeling.
Say again?
You
I
hurt
did?
My feeling, yeah. Why do you hear podcast out of MPTR?
So I mostly listen to this podcast for medical updates, and they actually invited like the president and the founder of AHPM. So for those that don't know, AHPM is like the American Association of Hospice and Palliative Medicine. This guy founded it maybe like, I don't know, like decades ago, 60 years ago, something like that. And people like him looked at hospice and said, well, why can't we bring that to people who aren't immediately dying, right? Like, why do the people that are immediately dying, why are they the only ones that got support?
Why is it too late, like far late? Why not starting it early?
Yeah, like
so
why is it
benefit?
right? Like, why is it only when you start suffering do you get support, right? Like, so people felt like, it's not fair, and we should probably try to support people that want that support the moment they're, well, as early as they start showing chronic illnesses that can't be cured. So that's kind of the origin of palliative care in the U.S. And you're right, it's such a new field. It hasn't even been 100 years old yet, pretty much, right? But that comes with its own problems, where even physicians, especially some of the older generation of physicians, still don't understand the purpose of palliative care. I'll just say a couple weeks ago, I walked into a patient's room. Patient's family loved me. Like, I've been giving them like updates, make sure that they were up to date and on the same page as the doctors, what we're doing, how he's progressing, how the person is progressing. And then the nephrologist comes in and goes, "You're palliative care, right? What are you doing here?"
How old was he?
I don't know, but he was definitely like an older gentleman, and you could tell like he's been practicing medicine for a long time. And then he comes in, he goes, "I'm from nephrology," and I'm like, "What are you doing here?" I'm like, I don't know how to answer that question. Like, I'm supporting this person.
Why do you ask?
Yeah, he basically implied, like in front of the patient's family, no less, like, "Hey, I don't think you belong here." I'm like, but you see how they're receiving me versus receiving you, right?
Yeah.
Like, they were like, "We have no idea who you are. Like, what are you here to tell us?" And then he just walks out of the room after being in the room for 2 minutes. And I had already been in the room for 30 minutes at that time. So I was like, I mean, I wasn't offended. I just kind of felt it was funny, because I knew that older physicians and even some of the newer physicians, for some reason or another, they feel like even palliative care is like, oh, someone's dying and there's nothing more we can do. Then they go on palliative care.
I think international residents too doesn't know about palliative care until they get introduced, if they get introduced to it here, because they don't go to med school here.
You know what would be really interesting is for like doctors to experience the palliative care style of like questioning that you do in navigation, so you can have an actual like experiential like understanding.
Well, I would love it if you had like a course for physicians to teach them.
Yeah,
Not
that's too
as much as like seminar, like webinar, to teach us what is palliative care exactly, because I don't know what's that. I didn't know until like you're explaining, Dr. Cynthia Pan explained to me. But I know a lot of people who are international graduates, and they came here and they start like doing the residency, fellowships. They didn't know what's that. Because it doesn't exist back home.
Yeah, so my hospital actually hosts a lot of foreign medical graduates. And that is pretty accurate. What you're saying is, when they rotate with us, the internal medicine residents have to rotate with us as a mandatory experience for them during their second year of internal medicine. And a lot of them will just be blown away by how we communicate with patients. They were like, "Wow, like, how do I learn the way you talk with people?" I'm like, you just have to do it. You know?
Be human, that's it.
Yes, it's being human, and it makes me a little sad that like these people are brilliant. They can pass exams with high scores. They can do all kinds of research. They have all these publications under their belts, and they're getting like accepted into difficult to match fellowships. And yet, the simplest ways of asking questions, they are hesitant and scared because they've never been taught to ask questions like that. And I think,
I think they've never been taught to be themselves. They were programmed to ask certain questions, so now it's like it's new to them. Like they don't understand it because they were programmed that way.
Yeah. And I will say it's not even for medical graduates. When I was a medical student, there was no palliative care training in my medical school. I actually didn't know about palliative medicine until I was an internal medicine intern, you know? So all 4 years of medical school, I didn't know palliative care existed.
You have just.
I don't even think I knew hospice was a thing back in medical school,
Yeah.
which is really yeah, that says more about my medical school than anything else. Like I know her medical school, like Columbia, had.
Well, they're really big pioneers in this space, so it's different. I
Yeah.
was exposed very early on in my medical education. Like one of the first like courses that we ever took and was a continued course throughout medical school was, I think it was called the Foundations of Medicine, which really strongly emphasized like internal like introspection, reflection, and communication skills.
Mm-hmm.
Oh, that's
So-
awesome.
So that was a really like fundamental part of our education. But my school is also very much a pioneer.
But that's
and
not in
bringing
all
that.
schools. I think that's special to.
Yeah, I mean her school was prestigious, right? My school was like new when I first started. Like I was maybe the third graduating class.
Oh.
Their curriculum was
So you're like the experience, like they experienced the new guys.
yeah, sort of.
Yeah.
They're like we got the basics bare
Yes.
bones down. Like we can give you the degree,
Yeah.
but we don't have much else to offer besides that.
Well, bringing the conversation back to palliative care, I feel like from now being able to listen to what you have to say, what I like imagine in my mind really is even like a simple slide of like
Yes, but
before my understanding of palliative care was you're dying, and now after my understanding of palliative care is instead of a statement, it's a question: what is important to you in this life?
yeah.
Mm-hmm.
And that's, I feel like that simple reframe says so much for what it actually is and could help people understand more about
Yeah.
when to actually apply it and engage with it. And I think it's actually hard to really, no, that's not what I want to say. What I want to say is I feel like it could actually improve our own quality of life more too when we engage with other people about these questions and are genuinely curious about what is important to them, because then we get to think about what is important to us too,
Yeah.
and learn more about ourselves as we learn more about other people.
Yeah.
Yeah.
I think a couple things. If you want to provide personalized, value-based care, you can't do that without knowing what the person wants, right? So it's kind of almost silly to say, oh, I'm just going to give everyone the standard of care because that's the standard of care. Like, I'm afraid of being sued, so everyone gets the standard. I think, me personally, I think that's the wrong way of practicing medicine. And the second part, what was the second part? Kind of lost. Oh, when you know a certain treatment is something that the person wants to do, like I write in my notes, shared decision making all the time. Like no decision from me
Without the patient.
is ever, like nothing I put into a patient's medications or treatment plan is unilaterally decided by me. It's always a shared decision making after the person understands all the implications of this decision that they're making. Like what's the risk, alternatives, risk, benefits, and alternatives. What are they? They expressed an understanding of that, and we made a shared decision to proceed with X, Y, and Z. When you do that,
Consent form.
yeah, well, yeah.
It's a
But-
consent
But
form.
when you do that, I feel like even if you don't necessarily agree with the choices that they're making, you feel more at peace because you know you're doing what that person wants to do for themselves. You know, like there's so many times where I work with people and they're like, I don't understand why the family still wants to keep going. There's no hope. I'm like, have you talked to them about that? You know, like a lot of times it's like, hey, have you communicated with them how grim the situation is, and if that's still what they want to do, that's what they want to do. You should be at peace with it.
Paint the picture.
Right. I don't think that, and that's another thing about palliative care is stepping back from the person that micromanages everything and tries to be the savior, right?
Yeah.
Stepping back from that and just saying like, I'm an expert guide for you in the hospital, in the medical setting. and whatever your decision is, I will respect, but please hear me out first in terms of what I think these decisions will lead you down, like the roads that these decisions will lead you down. What does each road look like?
It's great because you actually get to also present options to a patient.
Mm-hmm.
And then it's only when you have options, meaning that there's more than one way to see things, that you actually have a choice. And when you have a choice to make, then you actually have, like, you have choice, decision.
Mm-hmm.
This reminds me, like, recently I had a patient I was doing a procedure on, and then at the last minute the team called to ask, oh, can you actually, like, add on another procedure to this? And he was, like, already in the room. So I was like, well then, I mean, you haven't talked to him about this, but I'm gonna have to reconsent him and go through the entire explanation and process. And so ultimately the guy was just like, I feel so overwhelmed. What do you think I should do? And in that moment I was like, this is not the appropriate setting. Like, being in the procedure room, like, about to be prepped is not the appropriate setting
I would
to have this
100%
conversation.
agree.
And I was like, it would be really useful to have
Maybe his family present, like, when we
just
talk
in general,
about
like,
it.
I think the appropriate environment and setting, regardless of the specialty of doctor, but like somebody to really sit down with him and explain to him what the options are, so he can make an informed decision, like a truly informed decision.
I will say that I hear stories like that more often than I care to admit, and it really makes me angry when I hear family complain, oh, he was consented for this by himself alone, and he's confused. How could he have made a decision? I'm like, oh, I'm so sorry to hear that. Like, you know, like,
even in a daily basis, like Ali would come and I was like, if I'm busy, like something silly is like, what do you think? Should we do this or that? And I'm like, I can't decide right now.
Like, the setting, this current setting is not appropriate.
Let me think about it, and it's silly, like a silly decision. So how is it when it's a big decision, life changing?
Actually, that's really interesting, because I remember the palliative care lecture, one of the palliative care lectures that we got during medical school. There was an acronym that the guy used. I'm terrible with acronyms.
I hate acronyms.
But
me too.
It spelled out spike, and he was like, the
Yes,
first
that's a
letter
very
in
common
S
one.
is setting, and that was the only thing that I actually remember.
Like, for the record, I don't know any of the spike statements. I don't know the nursing statement. Like, there's a nurse statement, spike. I don't remember any of those things. I kind of just feel it out. Just be a normal person.
But
Try to
that
be a normal
reminded
person.
me, like, setting is actually very important. Like,
and the mindset of the patient.
Yeah.
you know,
Like he's like terrified of the procedure, so don't get another like something.
he's like, I don't even have like the basic foundational understanding to even make this kind of decision. And I'm like, yes, I understand that. And so, like, in that situation, what I ended up doing was going back to the team and explaining. And I was like, I understand why you think it's urgent to do now from your perspective.
That's a unilateral decision.
Yeah.
Well, the good thing in that case was that, like, I was, I guess, I mean, as a doctor, like, informed enough to also be able to have a medical discussion with them to say, like, you know, maybe this actually is not so urgent right now for XYZ reasons. Like, you're probably getting ahead of yourself. But in that instance, like, I, as the proceduralist, was able to, like, provide that kind of value and be like, you don't have to do this right now.
But you were confident with your way of thinking.
Well, mainly because so much of the way that I practice is so fundamentally informed by palliative care, because of, you know, just the way that I grew up personally, and then also from my intern year, I think the most value that I was actually able to provide patients was like a high level of palliative care style medicine. So I've like had those conversations before, and I like could ask those questions organically. But to your point, like you feel like palliative care is done a lot more organically for you. There's also like stuff in academic palliative care with all the acronyms and different statements that you can use as an outline. The interesting thing is, I remember in medical school, we had these OSCEs where you're supposed to practice like these different statements that they tell you. And I remember one of these OSCEs was for motivational interviewing to like help a patient like install lifestyle changes for themselves. And my initial raw score from that OSCE was a 3 out of 10 because I didn't use any of like
The statement.
The
Or-
actual
or, like,
robotic
the
term.
robotic
See, again,
statements.
algorithms,
You know,
right?
because I was like,
Yeah.
this just doesn't feel natural to me.
Mhm.
But then my preceptor, who is such an amazing guy, he's a psychiatrist. He advocated for me to not fail that when he was
Yeah,
talking
as
to
you
the
shouldn't
person
have.
scoring, because he was like, she fundamentally touched upon all of these different things, but just didn't use the literal statements that you wanted her to make. And so thankfully, I was able to
That's-
able to pass.
And-
Take us to programming. Too.
Yeah, but before that, I want to mention the reason I don't use those acronyms is because I think that's a good place for people to start out.
Yeah.
Like if you have no, like if you're like one of the foreign medical graduates or someone who never had palliative care training before, you have no idea how to talk to people. That's a good place to start to practice.
To be like awareness
Right.
of these.
Like to be
different
aware of these
factors.
concepts
Yes.
that you can work on. But once you're proficient, you kind of freestyle it.
Yeah. So you mentioned the procedure and going back to the team. Palliative care is known as like a team thing. So which person is a key in the team, like
Mhm.
key player in the team, and which role would they take?
So I want to expand on that question a little bit. I think everybody, first of all, can do palliative care, right? There's a
It's a style.
yes.
Yeah.
There's a generalist level of palliative care, and then there's an expert level of palliative care, right? And the only difference between those two is just how much more experience we have in terms of just this is our job. We talk to people every day. But if you're able to, practice generalist palliative care, even the floor nurses or like your clinic nurse or your receptionist can be a palliative care provider, right? Strictly speaking, in my practicing environment, we have the physicians. We also have nurse practitioners supporting us, and ideally they take kind of like the more straightforward, I mean, if anything is straightforward, but the more seemingly straightforward cases. And then we have a social worker that really goes into the more of the psychosocial, emotional aspects of people's experience and help support them from that way. Recently, we also got a chaplain added to our team. A chaplain is someone who provides spiritual support. Not necessarily, it can be a priest, not necessarily. In this case, she's Jewish, I think.
Okay, it's
Yeah.
different than
Yeah.
From each religion. Like it's different.
So they try not to be religious when they
Okay.
go in. They try to just be spiritual. Like, hey, what about this? What about this? Can we support you from a spiritual standpoint? If it's religious, like, hey, I want last rites and sacrament of the sick. Yeah, we call a priest to come and help you. But if it's just say, hey, I'm pondering my existence, like what does life all mean? That kind of question, they are very helpful in providing that kind of spiritual support.
I need that.
So I think that's our kind of our core staff. It's we rely a lot on generalists actually to do what we do, because again, I'm a consultant. I'm not the captain of the ship in charge of everything. I just sort of evaluate, provide my insight, and tell people, hey, this is how I think the person would be best supported, to keep in mind of these things. And then after that's identified, I think everyone can keep those concepts in mind. Like, hey, this person wants to go home, for example. Going home is the most important thing for them. Or not dying in the hospital, but dying anywhere else is fine for them. Like we've heard that before. I think one of the most remarkable cases that I've had in recent memory was a 90-something-year-old gentleman came to the ICU because he was no longer able to swallow. Like his esophagus was so weak from being 92 or 93, he couldn't swallow. So he ended up getting a tracheostomy and sent to a long-term nursing facility, because he told us that life is worth living as long as I can listen to Mozart. If I can still hear Mozart, I'm alive, I'm happy. And so we're like, if that is your bottom line, exactly. We did the trach, we did the peg, even though many people would have been like even his friends, they were like, we don't agree with this, but that's what he wants, we will support it.
If he's okay with it, that's what makes.
Good job, Mozart.
I know, Mozart, right? Yeah, he was an art dealer. Yeah, he gave me a book and everything.
See? Oh, he's an art dealer. He
He was an art deal. He made his money from dealing art, but he was in all kinds of art, music. He wrote poetry. He was apparently a really famous poet. Well, he's dead now, so I guess I don't remember his name, but I could share if I knew.
But that's what makes it special, like the relationship between the physician and everything is customized to the need and wanting of the patient.
Yeah, that's in essence, that's the most basic thing that you think we are basing medicine around. But I will say a lot of burnout these days happen because the physicians want to do one thing, the medical team wants to do one thing, and the patients want another, and they're not talking on the same page. So then the patient's pissed off. They're like, hey, you're not listening to me, and you just keep telling me to do the same thing over and over again. It doesn't feel like it's working to me. Why can't we change things up? And then the doctors are like, well, the patient's non-compliant. They're not doing what we want them to do, and that's a bad patient. And you're like, you're making enemies out of people you're supposed to care for. And of course you're going to be burned out because you're constantly having like adversarial relationships with people.
So how often do you see a patient? Let's say.
What do you mean, like once I start seeing them?
Yeah, once you start seeing them, let's say I'm your patient, how often would you see them?
So that depends. It depends on how much they need me there. Sometimes I see them once during the hospitalization, and I never see them for the rest of the hospitalization because it was a straightforward conversation.
So they don't do a follow-up visit or something?
So we do, and we can. So it depends on how complex they are. So for example, let's say I have a patient who was just diagnosed with COPD. But he's fine. He's like still working. He's doing everything he needs to. He's biking 12 miles a day. I'll see them and I'll say, hey, I'm here to support you. This is what I do.
No one has COPD.
Yeah.
Well, if he's doing the biking for 12 hours, I'm doing none. So I'm the one who's having some COPD.
No, that's just deconditioning. So, but you see, like if someone's that early, I'll say, okay, this is what I do. I'm here to support you, and you reach out to me if you feel like you have questions. So those kinds of people that I can just see once, and then they're usually good until the next time they either come into the hospital or I see them in the office. And then there are people that are like dying in the ICU. Day to day, it's different. So if things change day to day, or if there's significant changes on a certain day, I will review the chart and I go, they seem like they could probably use some more support, and I'll go see them again. Or they just call me, and I give everyone my card, and they're like, call me if you need me. They'll call me because nobody else is listening to them. Yeah. That's usually the reason. They're like, we try to reach everyone else. Nobody can answer my questions, so that I don't know who else to call but you. I'm like, okay, I'll come right now.
Yeah, especially if they don't have family members that can advocate for them.
Yeah, or sometimes family members, they're like, I try telling the nurses that I want to talk to a doctor, and no doctors come talk to me for the past 2 days. I don't know what's going on. And I'm like, okay, slow down. I'm coming. Kind of help reassure them, like, hey, there's still a team here to support you. You don't have to go through this alone.
That's nice.
I went through this experience with my father and my mother. We would take them to the hospital, and then no one's answered any questions.
Yeah.
And they would leave them like for hours without nurse checking, or like, I'm like, I want to know what's going on, and no one knows.
Right.
Yeah. So I think it's very hard, and I have so many ideas for you. Oh my god. I'm like, I want to ask him to do a curriculum, and then we can propose it to other councils, because this is very important.
Yeah, you can ask
I'm
him
not opposed.
Ask him on record, and then he has to do it.
Well, that will help a lot of patients. So another a question that comes to my mind about symptom management: what are the most common symptoms you help patients manage? You can you give us an example of palliative care? How might you address the symptoms? How often do you see them if they have a symptom and check on them?
Yeah.
Yeah.
Sure. So I think one of the most common symptoms I treat is pain. And usually it's like pain that's not responsive to things like Tylenol and ibuprofen, right? And necessitating the use of opioids. Yeah. And with the national opioid epidemic, people have just gone the other way. Yeah. They are now under treating pain, letting people suffer, which brings me back to my initial point. People are suffering for no reason. So they bring me on board for usually cancer pain, or they have severe lower extremity like peripheral vascular disease, like ischemic pain.
What about nausea from cancer?
Yeah.
What's the treatment?
So those symptoms are, believe it or not, usually pretty easy to manage, like things like Zofran. Sometimes the nausea stems from anxiety, so you give them some benzodiazepines and they actually stop being nauseous. Sometimes they're nauseous because they've been taking so many pain medication, and they're constipated, and nobody's addressing the constipation. So believe it or not, I deal with a lot of constipation. I'm like, I didn't realize palliative care had so much constipation to deal with.
I've seen a few x-rays.
And believe it or not, people end up in the ICU with perforated bowels because even if people feel comfortable prescribing opioids, they don't manage the adverse effects of opioids, which can be, they don't tell people be careful, like don't drive for 2 weeks. You have to take like bowel stimulants to keep the bowels moving, and so you don't get backed up. People don't do any of that. And then so anxiety, pain, nausea, dyspnea, so shortness of breath. There's a whole lot of dyspnea that I deal with. Sometimes it's due to pain. So if once you treat the pain, they actually breathe better. Sometimes it's due to fever. So I don't know what it is, but when people are at end of life, and we have this concept called comfort care, right? And people have this idea like, oh, he's comfort, I don't need to treat the fever. I'm like, what do you mean you don't need to treat the fever? The person's breathing 40 times a minute and they're so sweaty. Treat the fever, It's making them uncomfortable.
Fever is for me, is one of the most uncomfortable.
Yeah, absolutely.
Ever.
Like chills, like you're shaking, you're
and
sweating.
And it's like it makes my bones hurt.
Mm-hmm.
So why not?
Right. So fever is undertreated at end of life. Pain is undertreated at end of life. Dyspnea is undertreated at end of life. A lot of times people will see that a person is asleep and they'll say, oh, they're comfortable. But if you really stand there and count, they're breathing over 30 times a minute. That's not comfort. If someone's breathing 30 times a minute, they're not comfortable in my book. So those are some of the more common symptoms that I help manage. I think pain is up there. Anxiety and dyspnea are pretty close follow-ups, and then constipation. And then there are things like nausea and other things. Sometimes, especially with cancer patients, the cancer causes them to lose appetite.
Yeah.
So we can try to help with that too, but I tell most people that there's really not a good medication to help with appetite out there.
So do they take IV or?
You mean nutrition?
Yes.
We usually don't recommend it just because it doesn't really, there's really no evidence that it helps in those cases. And rather we have a more realistic talk with them about, hey, yeah, we can, first of all, IV, generally people don't want to do it. So like the medical team's not even offering, but sometimes they'll offer like a feeding tube.
Yeah.
And I'll tell them like, it takes away your joy of eating. It doesn't replace your joy of eating. And it doesn't even necessarily guarantee you a longer life. And on top of that, you're going to have a tube in you, either through the nose or through the stomach. And it actually increases your risk of aspiration, because if I feed you against your body's will, your stomach might reflux everything up and you're going to choke on it in your sleep or something like that. It happens all the time. So like I tell people, like there are actual risks associated with these procedures that people perceive to prolong their lives. Is actually you might choke on your food.
So I'm going off my questions, but when you were talking, I was thinking, do you think dying alone is a symptom of modern life and Western life? It depends on culture, and then palliative care is coming back and like save those patients, because the culture here, I don't know from how many years, but they program people to be alone. Like you're 18, you go out, you don't see your parents until you're like Thanksgiving or Christmas or whatever religion you holiday you celebrate. So does palliative care came in to fill that deficit, as you said? Maybe?
Yeah, we do to an extent. So we do it in multiple ways. I will say, to preface this, that it's encouraging to see that doesn't actually happen most of the time. So most of the time people actually have family that really love them.
Yeah.
And seldom do I see that a person is dying alone. I do, but I would say 8 out of 10 people do not die alone. Based on my experience where I practice, your mileage may vary depending on where you are. So palliative care, we can definitely directly come in and spend time with people. Diana and I recently saw a patient, like it was my patient, and we actually visited her on a weekend.
Oh, that's awesome.
You know,
That's nice.
the whole family was there, and everyone was really appreciative that we took the time to actually come in during a day that I'm not even working to visit. But even with just doing our daily routine, like I tend to spend more time than other doctors do, right, with my patients. At least 5 to 10 minutes is at the very minimum, even if it's someone I already know. And I talk to them, right? Even if they're unconscious, even if they can't talk back, I assume that people can hear me, and I talk to them and say, hey, it's Monday and it's morning time, and I'm here to check up on you, just make sure you're comfortable and things like that. So providing a little bit of that companionship. Now, I have indirectly led to people not dying alone. Like I've had patients tell me in the past, like, oh, I have family, but we don't talk anymore. And I would ask why, like, why don't you talk anymore? And sometimes it's really bad. Like, okay, I understand why you don't talk to them anymore. Like they stole your money and left you homeless. Sure.
Yeah. You don't want to talk to them.
Yeah, like I don't think they should come and visit you. They don't deserve it, frankly speaking. But then there are times when it's like, oh, my daughter and I just never got along, and like little arguments built up, and we just stopped talking to each other 5 years ago. I'm like, so would you want us to reach out to your daughter, and like, does she know what's going on? And then they'll tell me, oh yeah, they don't know, but yeah, sure, reach out, because secretly they hope that they can put aside their differences and focus on, and I've had a couple of cases where I have helped reunite a couple of families when the person is dying.
They said, no, we don't want to have anything to do with the patient.
There were a couple, yeah, and I mean,
That's we need to learn about breaking the news to the patient, not the bad diagnosis. I mean, how did you break it to the patient?
well, the patient usually knows. The patient knows what they did in the past to warrant that kind of reaction. But I would say that in those cases, we still provide, more close follow-up. Like I'll say to my social worker, hey, this person doesn't have anyone. Can you spend more time with them? And if they are enrolled in hospice at some point, hospice will also send volunteers over to just sit with them, or sometimes, music therapy that really helps people not feel alone. I think some states have the No One Dies Alone initiative, where if we anticipate someone is going to die, the hospital will have a sitter to sit with them so that they don't die alone. I'm not sure if my hospital is one of them, but every time I've asked for something like that, the hospital did provide.
That's nice.
Yeah, the tricky part is predicting when someone's going to die, which we are notoriously bad at, no matter how much training we do.
So you said like a while ago in this podcast, if I have 5 years left, I would change totally my life. So what, God forbidden, what would you do differently?
Me?
Yeah.
Stop working. That's what I would do.
I would prioritize time with my family
Yeah.
and my friends. Yeah.
What about you?
Same. That's the overwhelming answer I get when I ask people in the hospital, like, what's most important to you? They tell me I want to spend more time at home with my family. That's the number one answer I get. Nobody has ever told me they wish they had more money or they worked more.
I read a lot, like in the books, they say many dying people, many people at their end of their lives, that's the only wish they want. They never thought of like,
Yep.
well, I wish I had like a greater, prestigious job or
Yep.
like more money. Or,
If anything, I've had people tell me I wish I spent more time with my kids, because that's
Yeah.
why we no longer talk, is we never spend time together. I wish I spent more time with my kids so that today, as I lay dying in my bed, they would be here holding my hand.
I always say your relationship with your kid is like, it pays off later. Like what you do now, it's like a circle. What you do now, it's genuinely and normally will come later on. So if you spend time with them and
Yeah.
you actually were there for them, they won't leave you alone. And if you don't, they wouldn't care. Because they're in their mind, well, I don't know that person. I was with the babysitter the whole time.
Yeah, I think there's definitely a higher risk of ending up alone when you don't spend much time with your family to begin with.
So
Yeah, so that would be my answer too. I would stop working and just do what's fun for me, which is usually, hanging out with people and just talking and honestly sitting next to a fire.
Is it in hot weather? Houston
Well,
weather here?
cold weather or, just go do fun things and
I don't know. I would want to spend more time with my family, and I want to go to Spain. Just leave everything and just
yeah.
live there.
In Spain?
Yeah.
Yeah,
So your
well,
family's going to Spain.
Well, I'll take them with me. I'll rob a bank and take them with me. Oh,
Well,
that's just theoretically.
well, I remember one of probably the most impactful case for me when I was an intern was I walked in, and then that morning I was assigned a patient who's a 90-year-old man. I was told, oh, he's gonna be low maintenance because the attending has already worked out with him and his family the decision for him to go to subacute rehab. Subacute rehab is you go to a center, and then it's not super intense, but people will work with you to be able to regain function.
Okay.
Yeah. And so I was like, oh, okay. And then I remember my senior resident said, oh, but actually maybe it was you. Maybe it was you, or
I don't
maybe it was
remember this
someone else.
case.
But they told me
I don't think it was me.
they told me they were going back and forth about whether he should be hospice or subacute
His
rehab.
family?
Yeah, and then they're like, oh, but the attending talked to them, and then now they decided subacute rehab. And I was like, okay, okay. So then I start looking into this case, and this man has things that he had, his underlying condition results in electrolyte imbalances that we cannot even really keep up with all the tools that we have, with the IV supplementation and stuff. Well, he had enterocutaneous fistulas where your bowel is connected to your skin, and you're
Yeah,
just
so you're just constantly
leaking.
losing.
Yeah, and so I didn't really know much, but I was well, just from looking at the trends and what we've been doing, we're really lagging behind. And so I learned a bit more about his case, and then suddenly I got a call, oh, there's a family meeting for him to again decide the discharge plan, basically subacute rehab or hospice. And I was like, I haven't even met the man yet. So on my way to the room for the family meeting, I stopped by his room and I talked to him. I introduced myself, got to know him a little bit, and then I talked to him. And I remember asking him, I was squatting next to his bed so we could be at eye level, and I asked him, do you know what's going on? And he essentially said no. So then I explained to him that you have a condition that we can't fix medically or surgically, and the way that we're managing it is not really catching up to the losses that you have. And then I explained just a little bit more, and I asked him what is really important to you in life? And he said, I want to be able to spend time with my dog. He was like, I want to walk my dog. And well, first he said, I want to walk my dog. And I was like, is it the walking with the dog part or mainly being with the dog part? And he said, it's really about being with the dog in my family. And so I was like, well, I heard that you've been going back between subacute rehab and hospice. Why? And he was like, well, you know, I want to walk my dog. And I was like, well, we just clarified the fact that it's really about being with your dog and being with your family. And then I like briefly explained like subacute rehab and like hospice to him, and I was like, you know what, the family meeting for you is like happening. I'm gonna talk to your family first and get to know them, and then we'll bring like the discussion like back into your room, because they had already set it up. So I went into the room, and in the room his children were asking me, well, what do you think he should do? And I was like, well, I heard that you guys have this back and forth, so can you tell me your understanding? And essentially what they said is that, oh, like he was going to do hospice, but then at the last minute yesterday he decided to change his mind and do subacute rehab. And I was like, okay, like,
Do they know why?
and I was like, do you guys know why? And they're like, no, we don't know why. And I was like, okay. And there was another piece of the story that I had gotten before, which was that I had heard that the patient wanted to actually switch to subacute rehab for his kids. And so I was like, oh, I'm curious about what the kids are understanding and telling him that makes him want to do that. And so I was like, oh, there's so much miscommunication here. And so I was like, why don't we go into the room and have like a conversation all together? And I went into the room and started talking to him, and then suddenly I just got this sense that I should say something. And I said, you know, you don't have to work for your kids to know that you love them.
He wanted to work?
No, like you don't have to like do extra work, like go
Oh,
through
yeah,
rehab,
yeah.
knowing,
Yeah.
because he was like, doctor, like I know that I'm like dying, you know, like there's nothing really to rehabilitate.
Yeah. I'm like, if the hospital
And
is
like
not
he
keeping up
he
with
knows
him-
that because he's in tune with his body, you know.
Yeah.
He ultimately knew that, and I was like, you don't have to like prove to your kids through like putting in work that you love them. Like they know that you love them regardless. And he started like tearing up, and he was like, thank you for saying that. And I was like, so knowing that, and his kids were like on the other side of the bed, and they're like, yeah, no, we just want like what's best for you. And then he was like, well, knowing that, like I want to go home. And by home he meant like home hospice. And and at the time I remember like the sun was just coming up, because it was I don't know, very early. We start work too early in the morning, and the sun was like coming up, and the hospital where we worked at, they're like rolling hills, because it's like more in the countryside. And I was like, wow, that's such a beautiful just like landscape out there. And then everybody turned their head, and we just like were like looking out, like we just like had like a shared moment where we were just like looking outside together. And I was like, this seems like a pretty nice life to go to, like after you leave the hospital. And he was like, yeah, it is. And so like the whole family then like collectively had a plan, and he was able to tell them like, I really just want to spend more time with everybody. And they're like, we're totally going to arrange that now, like in the house. And now we have the support with hospice to do that. And like it was like, okay, yay. And then the next morning I remember I walked in, like I was on my first month ever of like being an intern. I walked in the morning, and he looks at me and he says, thank you for everything yesterday. You are an asset to your profession.
Aww. Yes, I agree. Yeah.
And I was like, well, I'm glad that we could get everybody on the same page based on what was important to you. And like that will always stick with me. And I think about him and like his family often from time to time, because they remind me about, they help ground me actually when I think about, when I get frustrated. I get frustrated a lot about random things that come up. But like it goes away relatively quickly, because it re-grounds me, you know, and it's helped to like define my value system for myself personally.
Yeah, you gave him something that if he had gone to subacute rehab, he would have never gotten.
Yeah.
He would have gone there, gotten dehydrated, they would have sent him right back to the hospital, and the next time he came back to the hospital, he probably would have died there. He never would have made it home, and you provided him with what's truly important to him.
Yeah, I really think that was like one of the most impactful cases that like two-way street
Yeah,
impact,
it's like in your first month, so it hit deep, you know?
Yeah, it did. Well, I think also what was impactful for me was seeing that it was like my first month as an intern, but I was probably more proficient in having these types of conversations than many of the people around me, as a product of like the life that I've led and the experiences.
Yeah, clearly even better than the attending who
Oh yeah.
convinced them to go to subacute rehab.
When you were saying the story, I was thinking, so if the hospital is not keeping up with dehydration, so how is
You can't.
You can't. Because he's also exerting himself.
So why?
And I think that's probably a couple things. The hospitalist was not comfortable with the idea of someone dying. And then the other thing was the hospitalist was not comfortable with himself or herself. I don't know who it was.
Well, I don't know. I think we would speculate like many reasons. Like they're very busy. There's a lot going on, and I don't want to speculate about things like that. But I think just more focusing on the type of impact that you can have when you communicate clearly and ask what is important to somebody.
For the patients.
Yeah, sometimes you decide that the buck stops with you instead of kicking the can down the road for someone else to deal with.
Yeah. Well, this also leads to my question of, after having gone through all of these experiences, especially like in your role as a palliative care doctor, what is your value system in life and how has it impacted it, if at all?
That's a very broad question. What do
deep
you
one.
mean
Like, what's
by
in- like,
value
what's-
system?
Like, I mean, I guess you already answered what's important to you. It's prioritizing
Yeah.
friends and
Yeah.
family. But I guess, how is it, if it has at all, it could be no, like maybe changed your perception about like life before and after?
Oh, sure. Like I would say before I became a doctor even, I think I'm always a person that focuses on like a lot of details. Like I would examine the details and sometimes I would get lost in the details and not see the big picture. But after I saw so much death, for the lack of a better word to put it, I realized that there's so many things in life that we worry about that just don't matter.
Yeah.
So I try to stop worrying about those things. And when I do worry about those things, I sometimes catch myself and say, is this worth my time to think about? And I try not to think about those things. So that's, I think, the biggest change in my life is hopefully the more efficient use of my brain and my conscious mind.
By directing your focus.
Yeah, like by directing my focus to doing things that truly matter and trying to...
Is it hard to redirect your focus?
It can be, because I tend to be the type of person that just perseverates on things, and I would find something and I just keep thinking about it. And that's still a problem. I'm not going to pretend like that's not a problem anymore, but I think the perspective I have now is that many of us, and myself included still, like I said, we worry about things that really don't matter. And so if we can cut out as much of those things as possible, we live more meaningful lives thinking about and focusing on things that do matter.
Yeah, so you know Carly because we were all at the UTI retreat together, right? And Carly, we just sat with Carly a couple of days ago, and what you're saying to me flows directly into what Carly and Alex are doing.
Yeah.
They're called like the Power of Flow
Presence.
couple, and their retreat is the Power of Presence.
Yeah.
And we were talking during that podcast about the importance of focus and how like your energy goes where your energy flows where your focus goes. And Carly, even just during a virtual podcast, much less not even in the retreat, really gifted us and our audience so many amazing tools to be in that power of presence in the current moment. And it sounds like that these two things are so complementary, where you're like, you through your experiences are now able to like choose what to focus on, and then like coupled with what Carly like gives, like being able to bring that energy and that presence into what you focus on. That sounds really nice.
Yeah, and I think I learn a lot from our cats. They really, yeah, we have 2 cats, and they really just live in the present moment.
Cats
right?
don't care.
Yeah,
So
cats
I-
don't
I-
care.
I
They're like,
love
they
that.
want to sleep, they sleep.
Yeah.
They want to play, they go crazy, and they play to their heart's content.
You know, sometimes I'm like, why did I
Become a cat?
like a cat? I don't have to think about anything.
Yeah.
Even when you have kids, you eat one of them if you're hungry, right?
You eat a kid?
Yeah.
No, like if you're a cat,
If you're a
sometimes
cat.
they eat the weakest one. Or,
Yeah.
So which
I want-
child are you eating first?
No, I'm not eating any child. I'll have an extra one to eat. So I want to shift from all of that to what you told me the other day overnight about the coaching, because it resonates with me. You advocate for revolutionary idea, implementing coaching for death acceptance.
Mm-hmm.
Early in the disease process, not just in final stages. Can you explain the psychology behind this and what this early coaching looks like in a practice?
And I want to make clear that I don't think that's a novel idea. If you examine Buddhist meditation practices, they contemplate death every day. So they meditate on the idea of death is part of my understanding is part of their beliefs. And the reason why I think it brings about peace is that if you can conquer your fear of death, like I said, there's not a whole lot of other things that will worry you, right? I think whether we consciously or subconsciously think about it, decisions that we make throughout the day, I'm sure you can at least think of one decision you made today that directly ties to the idea that I don't want to die. Putting on sunscreen or putting on your seatbelt when you're driving, right? Those can all stem from the idea that, hey, I'm a little anxious I'm not comfortable with dying. And I think my thought is based on, like, I'm not a Buddhist, but it is based on my knowledge of what they do. I really admire that. They don't glorify death. They don't want to die. They don't want to accelerate that process to their death. They just want to make peace with death in advance. And I think that's something that our culture here doesn't really do.
How do you do that? How do you become like at peace with death? Because I'm not at peace. I don't.
You already completed the first step, acknowledging.
Acknowledging it is important.
Well, I was in denial, but until Ali told me and I thought of it, and yes, I can't accept, like, if someone, like my loved one, and that started when my younger brother passed away in 2016. So it was like, I can't comprehend that I can't see him physically, and what is he doing now? Like, what's after death? And is he feeling lonely? Is he scared? So it's mostly losing someone. I don't care about my death. Like, I'm not scared of that. I'm scared about how the other people who I love would feel.
Very interesting perspective. Can I ask you, why don't you fear your own death, but you fear for other people's experience?
Because I love him that much. And I have this fear of, like, anyone feeling scared. I don't know why, even with my kids, I'm like, I don't want them to feel scared. This is the most, like, I don't know, like, it's the feeling of being scared is, I don't know how to describe it, but one of the most scariest, let's say, feeling ever. So I don't want one of my kids in any situation feel scared and not having me around.
Yeah, and
I think it's deep there. There is a trauma, but I don't know what it is.
So, my thought, I haven't fully explored my thought yet, so I don't want to pretend like I know exactly what I'm talking about. But I want to eventually provide people with a way to come to terms, whatever that may be, just come to terms with what death means to them. And that is probably personal and unique to everyone. Like, if you're religious, if you're a Catholic, right, you believe there's a heaven and you go to heaven afterwards, hopefully, right? But some people like me, I'm not religious. I feel like I'm spiritual, but I'm not religious. I've had experiences, spiritual experiences where I feel like I maybe got a glimpse of what death could feel like. And my experience was it was a very warm feeling where you were given a choice, very just neutral choice. It's not good, it's not bad. It just is. And whatever you pick is totally okay.
So what choice?
Well, I picked to live, but
So
yeah.
you get a choice of living or dying.
Right. So and that's how I experienced that spiritual experience, but I'm not saying that's going to be the same for everyone. But I do want to see if there's a way to provide people who are interested in that a similar experience where they can really make peace with their own concept of death. Like whatever they fear, that's going to morph their experience hopefully and show them like, hey, it's actually okay. Because that's something that we've never conquered, and I hope we never do conquer, because if we one day conquer death, there's going to be more issues at hand, right? But if we can't conquer it, our only option, logically speaking, is to accept it. Because the more the poem that says don't go quietly into the night, the more you get dragged into that kicking and screaming and fighting, in my experience, the more discomfort and trauma that actually causes for yourself as well as the people around you. So it's after seeing that, right? Seeing what happens when someone, very surprising. I had a patient who was 42 years old. He was diagnosed with terminal end-stage cancer, and he was like, I'm good. I lived a great life. I have a daughter. She's 6, but the mom is awesome. And we're financially set. Nobody has to worry about anything. I lived a great life. I played in a rock band. I have no regrets. I'm ready to go. Versus an 80-year-old telling me I want to live to 100, even though they can't swallow, they can't even speak anymore.
Any patient that says that?
Yeah.
Well, like suffering?
Yeah, these are real examples that I'm telling you. Like the juxtaposition here is like a 42-year-old who's already at peace with death, which I can't even imagine. Like that's really impressive, versus someone who is clearly at end of life from natural causes, even like dementia.
Yeah.
And the family or the patient themselves still, no, we want everything done. We want CPR. We want to be put on artificial life support. Because of fear, like the fear of the unknown, fear of losing somebody, fear of never seeing somebody again, that clouds their ability to accept a natural part of life. And so kind of just looping back to the idea of not glorifying it, but also like I think if you have a healthy fear of death, that's okay. I think that's an evolutionary process that we've all developed. Like we have a baseline, a healthy natural fear of death, because that helps us keep living and pass on generations, and but when it comes to a pathological fear of death, that's the part I want to address. The pathological fear of death, where it's like if death is mentioned, I can't talk about it. Like I can't even talk about death. I don't want to see death. Yeah.
Like I'm scared of it. I'm not scared of it. It's just I can't be at peace with the idea. But I want to talk about it more to understand it. Like I don't understand. Like we've been raised in a religious, let's say, community, and we were taught there is heaven and hell. And then when I grow up, I'm like, I think everyone will go to heaven. You know what I mean? What if there is no heaven or hell? What if there is no
What
life
if there is?
after?
Yeah.
What if there is no life after death?
Yeah.
So how can we see our loved ones?
I think like the most recent pope who passed away, I could be wrong, was it Pope Francis?
Yes.
Yes.
I remember reading, I don't know if it's true, but I remember reading a quote where he said, I like to think that there's nobody in hell, like hell is empty.
Oh yeah.
Yeah, that was sort of, I'm like, oh, is that like your workaround?
Yeah, well, I don't know, but I feel like everyone make mistakes, and unless you like you do horrible things, you're going to heaven. Like that's my idea of it.
So I would say, like, for you, for
Sometimes.
example, on a scale of not fearing death at all versus like on the extreme other end, like a very pathological fear of death, you're probably like somewhere around here.
Yeah.
Like, you're willing to talk about it. I have met people that are like, no, we're not talking about it. I'm like, okay, but so if you don't want to talk about it, what that means to me is you're going to get blindsided when it happens, right? So I think being willing to talk about it, to ask the questions, like, you know, I don't have the answers to your questions, but being able to discuss the
Yes, yeah.
topic and being interested, that already puts you closer to
Being
conquering that
yeah.
pathological fear of death that we all, you know, not all of us, but like I tend to see that pattern in this country. And that's not the case around the world. There are cultures that embrace the idea of death, like small villages here and there. They're like celebrating the end of someone's life rather than being so like they're sad about it, but they're like, you know what, this is the natural part of life and we're going to celebrate it just as we celebrate birth.
Interesting. Dr. Cynthia Plan, she was explaining like why would they celebrate like when someone had a newborn? They would celebrate and like
Mm-hmm.
ring the bell, and this guy, like this a human, don't have any achievement in life. While when someone dies,
Right.
they feel sad. They should celebrate their achievement and
Yeah.
their life, which is like it's a new concept for me. And like, yeah, that makes sense.
And for me, in my own head, it's like, if I don't die, how do I make room for my descendants down the road? Like, I'm going to be hogging all the resources. What does other people get? What do other people get to make sure they succeed?
Yeah.
Right? So I think you can't have life without death.
Yes. It's the
It's a
only
cycle.
truth in life.
Right.
Death is the only truth. Like we know it exists. Otherwise, everything is debatable.
Right.
Yeah.
So life and death is just two sides of the same coin. And I think that, you know, again, you don't have to chase after it.
Yeah.
But you should try to work your way towards understanding like what it means for you. And I also think that that's a very personal process. I have not fully developed what I think should be done to get people from point A to point B when we talk about relieving their death anxiety and relieving their pathological fear of death. I don't know what that process looks like yet, but I know that that's something that I'm interested in doing in the future, because I truly think that the experiences that I've been, you know, honestly blessed to have experienced, both directly and indirectly. Like indirectly, I've seen what it looks like in both circumstances, both extremes.
What do you mean?
So the guy that I was talking about, the whole family, they were like really okay with it. The kid, I'm sure, is gonna grow up fine, and that was like as good as it can be when someone dies.
Yeah.
And then we have people throwing themselves, bawling and crying on the bed after a person dies in the ICU, like refusing to let the medical team take the person's remains so they can, you know, give them a dignified
Yeah.
burial and things like that. They're like, no, you can't take them. Like, I'm not. So that is I'm trying to prevent that kind of scenario from happening if possible, right? In line with what you said, it's better to prevent
So
than to
is it
try to treat
the
afterwards.
fear of the patient is mostly there, or the fear of the family? Because I feel like the family has, like me, I have like fear of like losing someone from my family, and this haunted me all my past years.
Mm-hmm.
So and I'm still like there. I'm so scared of like losing one of my family, and I think we need that more than the patient themselves.
Yeah, I've seen it both ways. And I think first of all, I think grief is a very natural and normal human emotional process to go through. But then we talk about things like complicated grief, where usually, you know, after a certain amount of time,
It's
you know, like you're not happy about it anymore. You're not happy about someone having died, But then you also shouldn't still be like yearning for someone to come home even though you know they're dead. Like you shouldn't be like staying awake every night thinking about something. Like that's pathological. And we recognize that piece as a true like psychological medical disorder. We call it complicated grief, and there are real ways of tackling that. So what I'm trying to say is I want to prevent things from even moving into complicated grief. And how do I do that? I don't know. But I'm going to think about it.
She's going to work with you.
Yeah.
Yeah, I feel like she's very insightful. She asks the right questions. Like sometimes she asks questions like, oh my God, I never thought of that.
Mm-hmm.
You know, and it takes me to the direction. She really directs me, yeah. So I think she has, well, so I'll see what more questions I have. So yeah, the support for caregiver, like serious illnesses, impacts the entire family and support system. How do you prepare the family for that? And especially with everyone has to work, you have to pay your mortgage, you have to take care of the kids. So it's very hard to have like support your loved one when they're going through that.
And I think that's another encouraging thing that I usually see is that yes, life goes on for everyone, but the family are usually pretty in tune with what's going on, and they make time and space for it. To support them, I think the best way I know how to support them is again to give them the best information possible, so that they can help make the best decision for the person that's being cared for. Sometimes we clue them into resources that they actually have but are not aware of.
Yes.
And sometimes things like hospice is very appropriate, and they're like, we know nothing about hospice. We've never had anyone die with the help of hospice. I don't know what hospice is. So I clarify, hospice is a service that you really should take advantage of right now.
So what do they do in hospice? Like what services are provided?
Yeah, so I can go into that because that's a pretty important piece. So hospice is not a place for people to go die. That's the first thing. Hospice is a principle, and it's a service that's provided for people that qualify, like I mentioned before, expected life expectancy of less than 6 months, and you're no longer pursuing aggressive life prolonging measures, right? So once you qualify, there's actually levels of hospice, different levels of hospice. There's home hospice that they can administer in the comfort of people's homes, or if they're at a nursing home, they can also go to the nursing homes and provide hospice care. And that looks a lot like palliative care. Like we just come in and we ask you, how are you feeling? Do you need any support from me physically, emotionally, spiritually, or not, right? They have this very similar multidisciplinary team, like social worker, physical therapy, occupational therapy, chaplains, volunteers, music therapy sometimes, pet therapy, like as much as you want from them. But the basic is there's a doctor there, there's a nurse there, there's a social worker there, and there's a chaplain. Those four things are.
Is the nurse 24 hours?
So they can be, but they're usually not. Like if you're home care, they will tell you, okay, we support you medically, but we are not a primary caregiver service. So caregiving still needs to either come from the family, or people usually need to pay out of pocket for extra care. If that's not possible, then we're talking about moving people into long-term care facilities, which is like nursing homes.
Is that covered by insurance?
That is usually covered by so Medicare only pays for hospice.
Mm-hmm.
The medical part of hospice they pay for. Caregiver service is paid for by either their secondary insurance or out of pocket.
Oh.
With the exception of the highest level of hospice, so we're talking about inpatient level of hospice, where your symptoms are so bad or you have so much nursing need, like you need 24-hour nursing need, then you need to be in the hospital. Like you can't be anywhere else because there's no place else that has 24-hour nursing.
Yeah.
So that's the highest level of hospice care, and Medicare does pay for that aspect of caregiving because it's included in that inpatient hospice care. So hospice that occurs in the hospital or at like a hospice house, that's considered the highest level of hospice care. Whereas hospice that occurs at home or at a nursing home, that's home hospice care. I mean, you could be in like a homeless shelter or on the corner of the street, and hospice will come and treat you. Yeah. So that's home care. In between, there are two other levels. One is respite care. So people should know that if caring for a person gets too tough at home, they have a few days within each hospice benefit period where the person can actually go to like a hospice house or the hospital to give the caregivers a break.
Yeah.
And then there's continuous home care, which is the second to highest level of care, where if a nurse from hospice comes by at least 8 hours a day after the midnight mark, that counts as continuous home care, and that's also covered by Medicare. I would say the vast majority of people, probably over 80-90% of people, they're successfully managed at home or using routine home care. They may not necessarily be at home, like nursing home, homeless shelter, or truly a home. They're managed on routine home care. And then higher level of care is more rare. And truthfully, we don't hope people end up on the higher level of care because that means they're really suffering. Yeah. So the hospice principle is that they're trying to keep you out of the hospital setting as much as possible while still caring for all your physical, mental, and spiritual needs. And really looking after your dignity as you near death.
I think most people are more near death in that phase. What hurts them the most is losing their dependency.
Yes.
Yeah.
That's a big one.
Yeah.
Yeah.
Yeah, my mom passed away in July, and when she had stroke and start not moving, like she can't walk alone, she deteriorated emotionally, mentally, and physically.
People get really depressed. Yeah.
So that was one of the things that she hated. Like I don't want anyone to serve me. I want to be independent. I want to
Independence and functional status is more important. It's probably the second thing. Like the first is family and being at home, and the second is being able to take care of myself and not being a burden to my family.
I think that needs coaching, that it's okay to ask for help. We were not raised to do that. We don't ask for help usually. Yeah. So I think that's one of the most important thing, because they don't think it's okay.
And that's another cultural thing where, in some cultures it is okay. Like it is expected that, hey, when I'm dying, my children are going to take care of me. That is expected. Here, not so much. Here it's like, if I'm near dying, my children are going to stick me in a nursing home. And never come see me again.
That's one of the things that I don't like, because I feel like parents give a lot. Even if they are busy, they do give a lot if they are good parents. And I can't see an old man alone or old lady alone. It just breaks my heart.
Yeah.
Yeah, children and elderly, just,
Yeah.
So what do you think the most misconception you wish that you could dispel about palliative care, and where do you see the field going in the future years, like 5 to 10 coming years?
I think what I mentioned in the beginning is the biggest thing. Like people need to get the idea of palliative care means you're dying. That they need to just dump that. Yes, you have a serious illness, but I think that deserves good support at any stage of the disease. So if people can get rid of that mindset, it actually allows us to intervene earlier and potentially save people a lot of grief. And I think that's beneficial for hospital systems too, and that's why going forward, I do see hospital systems and big medical systems really pushing the involvement of palliative care earlier, because they also see that when we get involved earlier, there's less aggressive care, which often can only causes more harm rather than doing anything good. when that aggressive care is rendered during the last few weeks of someone's life. So if we can save people from that, the byproduct of that is we're also saving a lot of resources, because all that intensive care that happens at the end, like we're throwing the whole kitchen sink, spending more and more and more money with less and less and less returns. And more suffering, causing more suffering with all these procedures, all these medications that make people feel dizzy, nauseous, and confused, right? And that's not doing people any good. So the hospital systems and medical systems are really starting to see like we're pivotal in changing that landscape of doing everything we can. Sometimes it's better in medicine to do nothing than it is to do something. And we help define when and where that is.
Doing nothing is like, it's not the outcome that public society would expect from physician.
And let me clarify, do nothing in terms of medical intervention, life-saving medical intervention. But there's always something more we can do.
No, but like most of the people, as you said, they would come and think the physician can like make a miracle.
Miracles, right? Yeah.
So the expectations are not realistic.
Yeah, and sometimes that's a hard conversation to have with people, because I've had conversation like that, like, hey, sometimes it's better to just do nothing, and they go, so what are you telling me, I should just die? Like, no, we can make this whatever time you have left to be as comfortable as you can, and have you surrounded by your family, and make sure you're not suffering as the first and foremost thing. There's a saying from one of our palliative care doctors that we can't put more time in this person's life. We can't give this person's life more time, but we can put more life back in this person's remaining time, right? So switching that focus from do to, okay, let's hold on, let's zoom out. What are these people's value? What's this person's value? And how do we maximize this person's values? That's really what I consider to be good care. And in my opinion, that should be done every step of the way, whether you have a serious illness or not. I really appreciate, for example, when I went to see Ali at the dental office, his intake asks a bunch of questions that's what's important to you. I'm like,
He didn't ask me that.
well, because he knows you, right? But I'm
He
like,
doesn't want to know.
but I'm like, I'm really impressed, because what Ali is doing, he's practicing palliative care in his dental office by asking these questions like, what's important to you for your, like, how would you rate what you have going on right now? What would make it better? What is something that you want, to protect in your smile or whatever, right? I'm like, these are palliative care questions.
He didn't want to work for anyone. He wanted to have his own office, just because he's like, I want to have like a good time with the patient. I don't want to have like 5-minute
Consultations.
And just walk away. I want to have like the whole thing, what's important to them, and no one would come and tell me, well, your time is up, you have to go to the next patient. So that was very important.
And that brings up a good point. A lot of time, and it happened to me too, when they were asking me those questions, I was like, I don't know. That happens to me all the time when I'm like, hey, what's important to you? And the patients will be like, I don't know, nobody ever asked me that before. Okay, I get it. So take some time to think about what's important to you. And that's what I would encourage, like, anyone hearing this, is to really think about what's important to you, and encourage, like, whoever you're caring for to think about what's important to them. Because the more we keep that and in the center and stemming out from that, the better the outcomes, in my experience, things will have.
I don't know what's important to me. I have so many things I feel like.
And that's okay. Yeah. It's not just one thing. I usually tell people, hey, if you're having trouble deciding, give me like 3 or 5 things.
I have curiosity about his answers from Ali's. Not really?
I guess. But do you know what they are?
Yeah, they like have me rate how satisfied I am with my smile and all that stuff.
How
and like,
satisfied are you?
I said like a 7. you know? It's like, what would make it better? I'm like, oh, maybe like less gummy, if like less gum at the top, right? But I'm like, oh, in the grand scheme of things, I just want my teeth to be functional and not in pain. Like, what's important to you when it comes to your teeth? I'm like, I want to be able to use them. I want to have teeth, and I don't want to be in pain. Like, I hate pain.
I guess I knew that already, which is why I was curious.
Yeah, that's like that. Those are literally the most important thing for me. I'm very
I don't think
functional.
He cares that much about how it looks.
It looks good. Like there's nothing wrong with it.
Well, yeah, like as long as it's not like all over the place where it hurts when I chew. You know.
Yeah, he's not very aesthetically attuned.
Yeah, they're not the whitest teeth. I don't need them to be the whitest
Well,
teeth. Yeah.
Eddie's path in his practices, like he doesn't do that like white teeth, hollow and smile. What I like, he does it naturally, like what fits you. I don't like when you smile, I have to have
Wear sunglasses.
Yeah. Yeah, it's crazy. It looks fake. It looks like dentures.
But see, some people love that.
Yeah.
And I'm like,
because it's a trend.
and yeah, so I'm like, I love these questions because it really helps you focus on what's important for people.
Yeah.
And I think that's why I think his office is probably the best one I've ever been to, or ever will be to.
Well,
You know, unless people start modeling his office. I'm like, dude, I'm really impressed. You know, like
It takes a lot to impress.
Did I tell you the past 20 years? Nobody has ever mentioned that the glue on my braces.
Oh my God. You know, Juju went to him when she came to the U.S. and he was furious because she had braces and she took them off right before she came to the U.S. So the dentist saw her. They didn't tell her she had caries in some tooth, and they didn't clean it to her. They didn't do any cleaning. They didn't do anything. And Annie was like, seriously, when is the last time you saw a dentist? And she was like, 2 weeks ago. He was like, now she's scared to go to him. Like, he wasn't furious about you. He was mad at the dentist who didn't tell you anything.
Yeah.
Yeah.
He sounds a lot like me. Like, I get mad too when I'm like, they didn't tell you that we found masses on your lungs and they had me come talk to you already. That's not okay. You know, like
The communication is one of the.
Ollie should see my teeth.
Why?
It's not good.
How do you know?
Oh, we'll talk later.
Okay.
you should answer those same questions.
Yes.
I know.
what's
Yeah.
most important to
I
you?
know. Yeah.
Right. So I think and that just reinforces my point. Anybody can do palliative care. You just have to have the mindset of doing it. And you don't have to do as extensive as I do. Like clearly if the conversation gets more involved and more nuance is needed, have me on board. But if I'm just getting consulted to say, hey, can you ask them about someone's resuscitation status? Like you can do that. You know, you should be able to do that. And it makes me sad that you can't do it.
Yeah.
You know.
So I hate to end this, but that was like very, very informative. Thank you for
Awesome.
driving all the way and coming here. I really appreciate
No,
it.
thank you for giving me a platform for really getting everything that I do on a daily basis, kind of out.
It's very informative for me too. So I got so much knowledge from you. Thank you so much.
Great.
The other thing, if someone is listening and wanna find you, so how can they find you?
Yeah, they can reach me through email. My email is Dr. Dr. Lipan, Lipan, DO @gmail.com.
What's the DO? Because I'm not familiar with the
So
acronyms here.
in the US there's DO and MDs.
Okay.
So MDs is like your traditional allopathic medicine pathway. In my history I only interviewed at 2 schools and got into one. So I went to the only one that took me, and that ended up being a DO school. So DO stands for Doctor of Osteopathic Medicine.
Oh my God.
So I had some extra training in osteopathic manipulative medicine.
Believe in it?
Some of it I do, some of it I don't. Some of it I'm just like, I think this is like outdated
It's
nonsense.
Like medicine too.
Yeah. Like some of it should be thrown away.
Yeah.
So that it could become more credible,
Yes.
in my opinion. Because if you're telling me that you can feel the pulses of someone's brain, that's gonna make my eyes kind of roll back. No offense to all the DOs out there listening.
It's so right to say that, because I come from MD background, and there are so many things that we should get rid of and replace it with other things.
So what I do believe helps is the myofascial techniques that we do. Like, for example, one of the only techniques I still do infrequently is redoming of the diaphragm, which is to say I put a lot of pressure on the diaphragm and actually restrict people's movement to kind of reset it. I mostly do that for people with hiccups in the hospital, actually, because that can become very annoying and people can actually become very distressed by having hiccups.
Scare them.
Yeah, I mean, that you could try that too. That usually doesn't work. But we don't have any good medications for hiccups. Like, you could do Reglan, you could do Thorazine, whatever, but it's like hit or miss.
Does it take hours for some people, like, on hiccups?
Oh, I've seen people have hiccups for 2 days straight.
Oh my God.
And at that point, I'm like, let me try something. So I tried redoming of the diaphragm, and it sometimes stops their hiccups. I'm like, I didn't use any medications that have adverse effects. All I did was kind of lay hands on you. If it doesn't work,
We didn't use anything.
right, it's such a low risk thing to do. If it doesn't work, it doesn't work.
Yeah.
But if it does work, hey, I just fixed your very annoying symptom without having to do surgery or give you medications. So I do believe there are benefits to it. Like, a lot of times athletes will sustain muscular strains and their fascia tightens up, or they have some ligamentous strains.
How is that different from chiropractor?
I don't know if I'm qualified enough with chiropractor to answer that question, to be honest with you. All I know is our techniques are a little different.
But still, you're using the body itself to heal itself.
Yeah, so that's the same. The idea, I think, is the same. The techniques may be different. The training is different.
Yeah,
I don't have any training in chiropractor, so I can't speak to it. I will just say that whenever I do some OMM on her, she really likes it. So Osteopathic Manipulative Medicine, yeah.
So do you give pills or something?
It's kind of similar. Some of the techniques are similar in effect to like Jill with monopilates and health, her like myofascial release.
Yeah. When you said myofascia dome, I'm like,
You can try it afterwards.
I don't have hiccups.
You don't need hiccups.
Oh, okay.
It's the
You
same,
could do
it's
it
the
on
same-
her at this point. You know how to do it.
Yeah.
Like, you feel a difference in like how, like, when you do it, all of a sudden it
It's
feels
similar.
freer.
What he's talking about is very similar to what Jill teaches with the mono-orbs.
Oh, okay.
Yeah.
Yeah. And then like the chiropractor, you know, like that
Oh, yeah,
thing.
yeah.
Like, we do that too. It's called HVLA, high velocity, low amplitude.
You're good with acronyms, see?
Yeah.
Yeah. You don't
Only
feel
because
so
that
good.
was hammered into me
Yeah.
during school. That I don't practice as much, because that, in my opinion, feels more like cracking knuckles. Like, this is HVLA. If you're cracking knuckles, that's
Yeah.
HVLA. So you're hearing a crack. It feels good. Does it actually fix anything? I don't know.
Yeah.
I don't really believe it.
Yeah, I have this habit of cracking my
Yeah.
some people
But
can't hear it.
But I think, like, really helping to, first of all, identifying dysfunction, and then helping to facilitate,
A rebalance.
right, rebalancing the dysfunction to help the body move things along. Like, the other thing I think really helps is lymphatic drainage,
Oh yeah.
right? Like, if you do like lymphatic drainage in someone who's having like sinusitis or allergies, that does help. Yeah.
Oh well, thank you again. Thank you so much.
Thanks for having me.
Thank you.
That was fun.
Yeah,
Bye.
we have so much to work on now.